Hi, today we're going to talk about having a patient with an EVD, also called an external ventricular drain. As you can see here, we have our patient with our EVD. So we use EVDs because the skull is a fixed compartment. You have brain, CSF, and blood in it. And the problem is when one of those things is increased, then it can push the brain down and cause herniation, and we do not want that. So we use an EVD for two things. We monitor our intracranial pressure, or ICP, with our EVD, and we also help to actually drain off extra CSF so that we do not have herniation in our patients. Your cerebral perfusion pressure is what we call the pressure inside the skull. We get that using our ICP and our MAP. So it is your MAP minus your ICP. So sometimes these patients will have really high blood pressures just to help with the cerebral perfusion pressure. And a lot of times we don't want to lower their blood pressures if their ICPs are still high. Usually want your cerebral perfusion pressure to be at least 60, but your physician will tell you that exactly. A lot of times you can have a higher ICP in your patients with trauma, severe brain injury, hemorrhage, or large strokes. And the EVD can help decrease morbidity and mortality by having your patient not herniate. So Jenna's going to go over what the drain actually is and how we use the drain in our patients.
When zeroing your EVD, if your patient is open to drain, you're going to want to make sure that you take this stopcock off to your patient. You will then make sure before you zero that your transducer is at the level of the tragus. You will then drop your drain chamber down to 0. You will turn your transducer off to patient, unscrew your cap just loosely to make sure that it maintains sterile. You will go to your monitor just like your Artline and CVP to 0 ICP. You'll get 2 beeps and make sure that you wait for the 0. Once you get your 0, you'll come back to your transducer, screw your cap back on tight, take your drain chamber back to the prescribed order level, paying close attention to either millimeters of mercury or centimeters of water. It will specify. In this case, we're going to go to 5 millimeters of mercury. Once your drain chamber is secure there, you'll come back to your transducer, flip back open to your cap, and flip your stopcock back open to your patient. I'm going to chat about the EVD and its pieces and the parts that you're going to have your hands on during the shift. So we'll start over here with the drain that's hooked to the actual pressure monitoring device that's going to be inside of your patient's skull. You will have a dressing over top that should be occlusive. Nursing can change these dressings whenever they become soiled or they're non-occlusive anymore. And as you can imagine, hair, if they don't have a great haircut from neurosurge, it's a hard place to get it to stick. Coming out from your dressing is going to be your drain tubing that leads over here, drain chamber where you will get where your CSF is drained. You have a stopcock clamp here and a white clamp here. These are 2 things that nursing should never touch. If you follow your drain back, these are the pieces that you'll have your hands on during the shift.
So when you are checking your drain every single hour, Jenna already went over how to check the drain. The things that you're going to be looking for is you're going to look at how much output your patient actually had that hour. So again, you're going to look at your drain chamber. You will turn off to the patient and then observe how much CSF is in here. Anything 20 and less is pretty normal, but this would be a trending number. So if you're having, 2 out and then all of a sudden you have 20, that might be something that you want to let your provider know about. Or if you've had 20 out every hour and then all of a sudden you don't have anything out, that would be another thing to let your provider know about. You look at the color of your CSF. Usually normal, it's a yellowish color. The clarity, it should be clear. You shouldn't have cloudiness or bloody output, but sometimes right after the EVD is placed, it is bloody. Again, this is something that you would just trend, and then you would let your provider know if there was any change. So if it was clear or it was a yellow clear and then it became bloody, that would be something you would want to tell the provider about. To actually empty this down into the bag, you would just open this up like Jenna showed you how to do, and then turn it back off. When this bag becomes 2/3 of the way full, you do want to change out this bag using sterile technique. I found it's easier to actually have 2 nurses and just you be sterile to be able to take the bag off, hand it to the other nurse, and then sterilely put the new one back on. If your neurosurgeon or your doctor wants a CSF sample, you as the nurse should not take it. Remember that this is within their ventricle in their brain. You do not want to aspirate brain matter and have that be on you. A lot of times they will want to maybe take the sample from down here. We would actually want them to take it right here if you had not changed the bag recently so that it's a sterile sample of CSF. You also want to check your ICP every single hour. So again, you turn off to the drain, so open to the patient, to the transducer. A normal ICP is anywhere from 5 to 15. Usually you will have an order, or you should make sure that you have an order for when to notify the provider for a certain ICP. The order is usually above 20 for 10 minutes, but it does again depend on the patient. And like Jenna said, wait for the good wait form, and then you would record that ICP. If you have not had any output, there are some ways that you can troubleshoot the drain. So there's actually a sign that you can put at the bedside. It's laminated and it's in our ICU. It's called Follow the Drain. So F is for fluctuation. So if you are not having any type of fluctuation or drainage from your chamber, one thing that you can do is you would want to be careful about this, but you can actually, while your patient is still open to drain, you can slowly drop your whole system, and I'm going to have to undo my safety clamp up here so that I can actually drop it. And I just look to see if the fluid that's in the tubing, if it moves. If it does not move when I slowly lower it, then that tells me that there's a clot in my system, and neurosurgery would need to know that. O is for open to flow. So again, making sure that if your order is to open to drain, that you actually don't have any stopcocks that are clamped. We always need to make sure before we leave the room that we are open to drain if that's our order. L is level of the drain matches the order. So again, we want to make sure that in millimeters of mercury or water that the drain is exactly where it needs to be in regards to the tragus of the patient. And that is the reference point. Level to the reference point is usually the tragus, which is the middle part of your ear, right here. O is observed for obstruction of the catheter and CSF leak. So you want to make sure that you don't have any leaking in and around the EVD site itself. So look at your dressing and make sure that there's not clear drainage around the dressing. And W is watch for waveform and output. This is your normal ICP waveform. There's actually 3 different waves that you should see. So P1 is the arterial pulse, P2 is the cerebral compliance, and P3 is the dicrotic notch, which is the closure of the aortic valve. So this is what you would expect to see when you see an ICP reading. If you're not getting this reading for any reason, that would just be something to bring up to your provider or your other nursing colleagues to help you kind of troubleshoot if you need a new transducer or what's going on.